Hey guys, Woodruff here. So let's now talk about rheumatoid arthritis. The last video was about osteoarthritis. As you're now listening to this one, it'd be really helpful just to think about, okay, how is it different or comparing it to osteoarthritis? So, and I don't know how always, I somehow manage when I, try to make my PowerPoints look a little nicer. I always imagine, I always end up cutting off my memes, but this should say that my immune system attacks itself. What is your superpower? And so rheumatoid arthritis is different than osteoarthritis. Remember, osteo, bone problem. Rheumatoid arthritis is actually a systemic issue. It's an autoimmune disease. And disease, that sounded weird. It's also chronic, but the difference is that it has periods of exacerbations and remissions. So they kind of have like flare-ups and things like that, where osteoarthritis is kind of like, hey, my joint, like the joint doesn't get, you might have good and bad days, but there's not flare-ups. It's just I have no cushion. Whereas rheumatoid arthritis has periods where the actual joint space gets inflamed. There's inflammation, inflammatory particles. The body is attacking itself at the joint space. Now, there's not actually a problem in the bones. This is not a bone issue. This is a joint space issue. This is an inflammation in the joint space issue. This happens in different ages too, compared to osteoarthritis. When we talked about osteoarthritis, we said, it's related to or associated with older age, whereas rheumatoid arthritis is more common in women, and usually they are first diagnosed, I want to say, like when they're 30 or 40 or in younger age. So most autoimmune disorders are diagnosed in their ages 30 to like 50, I would say. And the difference here too is it can lead to very severe functional limitations because when with untreated rheumatoid arthritis, they can have very severe deformities to the point where they can't even perform like day-to-day tasks and things like that. So you want to think about overall here when we talk about osteoarthritis, um, you know, when we're looking at it big picture, is this bone on bone issue that can lead to pain and stiffness and day-to-day mobility issues getting up and around. Because remember, it's those weight-bearing joints. And so we're giving medications and treatments to treat the symptoms and improve their flexibility and their movement. Whereas rheumatoid arthritis, this is a inflammation in the joint space, and we do give medications to treat that inflammation, but most of the treatments for rheumatoid arthritis are to stop them from flaring up so much or stop their immune system from attacking itself. What do you call it? It's a little bit different, and kind of like getting your minds is that when we're treating osteoarthritis, we're treating a bone problem. We're treating rheumatoid arthritis, we're treating a systemic issue. We're treating an autoimmune disease. So really the medications and the treatments for rheumatoid arthritis are about treating the autoimmune issues mostly, whereas osteoarthritis, we're trying to more treat the symptoms. Because rheumatoid arthritis has a lot more to it when it comes to full body issues. It does have joint problems too, which is why we talk about it here, but and it is primarily in the joint issue, but it can lead to other stuff. I don't want to spoil the surprise for you. So same like osteoarthritis, the main symptom is going to be pain or stiffness. We're going to do a lot of the same assessments, but the answers are going to be different. So we're going to assess, okay, where are you hurting or having stiffness? Now, remember, in osteoarthritis, they have it on one side, like it might be their right hip or their left knee or something like that. Whereas rheumatoid arthritis is usually the small joints, like I said, the hands and the feet, and it's usually going to be both sides, so symmetrical. So they're going to have rheumatoid arthritis in their hands or in their feet. I was going to say feet, but just to be cute, but I'm not going to do that. So needless to say, it's going to be bilateral small joints, hands and feet, compared to osteoarthritis, which is one-sided, weight-bearing, or larger joints. Remember too, we talked about how we're going to assess that joint. We're going to look at it and see, what's going on with that joint. And when someone has acute inflammation, this is an acute inflammation issue in the joint space. And again, there's no problem with the cushion. There's no bone on bone here. All there is inflammation at the joint. Still causes similar symptoms, but it's a different problem underneath. So if someone has inflammation at their joint, what is it going to feel like? It's going to feel warm, inflamed, tender. It might be enlarged. Things like that. We're also going to assess for deformities. So, when you're thinking about osteo versus rheumatoid arthritis, osteoarthritis has the nodes. And so I always think osteo, like the nodes, the O in nodes is like osteo has nodes, and then rheumatoid has deformities. So, what do you call it? I thought I had a cool thing to remember deformities in rheumatoid arthritis, but it's not hitting me right now. Um, it might just be that the rheumatoid, like, it ends in D and D for deformity, so rheumatoid, they have, deformities. But there are 3 types of deformities, and we're going to look at these. It'll be a lot easier to explain them looking at pictures, so I'm not even gonna try to explain them right now, but, osteoarthritis has nodes, rheumatoid arthritis has deformities. We're also going to look for those systemic symptoms because, like I brought up, patients with rheumatoid arthritis, the autoimmune is attacking their joints, but it also is attacking other areas of their body. So these patients, most patients with osteoarthritis, their first symptom is the joint stiffness or joint pain, where someone with rheumatoid arthritis usually present with like just general fatigue, loss of appetite, weight loss, more general symptoms versus, hey, I have a joint problem. And they have joint symptoms too, but usually early on, it's the systemic symptoms. And then we want to ask them about their pain if it gets worse with activity. And then for both of them, their pain can get worse with activity. So it's not like one is one and one way is the other. But remember that difference in the stiffness is that for osteoarthritis, their stiffness in the morning gets better after about 30 minutes. They just need to get up and get moving. For someone with rheumatoid arthritis, it's persistent and it usually lasts at least 60 minutes or more. So let's talk about these deformities. So the first one is ulnar drift. Ulnar drift is kind of see how like think something that's drifting is kind of deviating in a certain what do you call it direction. And so the ulnar drift is everything deviating towards the ulnar side of the wrist. You can sort of see how the fingers are kind of drifting in that direction. Boutonniere's deformities, those are more in the you can have it in your thumb or you can have it in any of your fingers. I want to say, do I? No, I don't have it on. I feel like I had a picture on a different page, but needless to say, I'm just losing my mind. So the boutonniere's deformity is like think bending of the fingers, where they can definitely get kind of in a stuck position or like a hyperflex position. And then there's swan neck deformity, where the ends of patients with rheumatoid arthritis, their hands, their fingers can start looking like a swan's neck. So this is where you can kind of see it here in this. So they have the 3 different deformities as a part of their symptoms. And then the other thing that's different for rheumatoid arthritis is they usually have multiple non-joint issues. They usually commonly have other issues, like they might have other autoimmune conditions like Sjogren's or Raynaud's, or they get, excuse me, sometimes have carpal tunnel as a result too, but you can kind of see it can cause like systemic inflammation in almost all of your organs, a lot of itises. But it's pretty much your body attacking and causing inflammation throughout your body. So, how are their diagnostic studies any different? So, one thing that we're going to note is going to be that, remember, we talked about where they can do that joint aspiration, and you can kind of see it in this picture here, where they go into the joint and they actually remove some synovial fluid or joint space fluid. And with an osteoarthritis patient, we talked about it would be clear, but for rheumatoid arthritis, there is inflammation in the joint. So, what are we going to see? We're going to see cloudy or straw colored fluid. The X-ray, we cannot use that. It's not diagnostic when used alone, but we may do it just to kind of see what's going on. But they can have some similar stuff also to osteoarthritis. They can have some joint space narrowing a little bit. It's a different issue, but it's really hard to catch inflammation itself on an X-ray. So it's not the best test. One thing that would be a little bit a better test would be looking for signs of inflammation and looking for signs of autoimmune disorders. So there's a couple tests that are more specific to rheumatoid arthritis. The top 2 ones that we usually check are one that's known as RF factor and another one that's known as anti-CCP. And you do not need to know the deep patho of what these tell us or how they work, but effectively, they help to let us know that the body is attacking itself. So if people have positive RF factor or anti-CCP is present, these are both, like, I think your book says something like 80% chance that they have rheumatoid arthritis. Sometimes we'll also do an ANA, but that's more general versus specific to rheumatoid arthritis. The one that's the most specific is gonna be the RF factor, but the anti-CCP is a pretty good one as well. And then, so that's going to tell us, hey, there's an autoimmune disorder going on. The other thing that we're going to check is for signs of inflammation, like a CRP or ESR, which we talked about. This is our C reactive protein or our erythrocyte sedimentation rate. And both of these tell me that there's inflammation. So effectively, these diagnostics are telling me there's inflammation. And again, these just tell me there's inflammation somewhere. But then if I do that joint aspiration, then I can see, hey, there's actual inflammation happening at this joint cavity. And then we also might do some of those tests, like I mentioned, to see is there an autoimmune process going on. So this is going to look very similar. The one thing I added here is that the rheumatoid arthritis is going to be better if there's less frequent attacks or exacerbations. Because, part of this, I'm managing the autoimmune, and autoimmune conditions are managed or seen as being well managed when they're not having so many attacks or their exacerbations, like, where they're constantly like, kind of think of it like asthma, like we talked about with asthma, where someone can have asthma, but then they're not feeling a lot of symptoms all the time, but how often are they needing to be rescued, or how often are they having the exacerbations or getting triggered? And we're going to talk about medications we can give to treat acute problems like the inflammation. Then we're going to talk about meds and other things we can do to stop them from attacking themselves so much, because that's really the long-term goal. But then there's also the stuff with the joints, less pain, less stiffness, better range of motion, movement, or ability to take care of themselves, especially with these patients. When I talked about how bad the deformities and things can get, functional ability is key, and joint protection. We protect both of their joints, but joint protection is so key. We're going to go over some strategies to help a patient with rheumatoid arthritis. So this is where in class we're going to start making a table, but it's great at home as you're following along. Start making a table. I have a couple on my Google Drive, and then you can also make a simple one yourself and just like write out the differences between these two. So, like I mentioned, there's going to be some medications to help acutely deal with inflammation or pain. And so things like NSAIDs, steroid injections can help with that acute inflammation. We might also give some meds to suppress the immune system. So this is like to stop them from attacking themselves so much or decrease that autoimmune. We might give something more like systemic steroids. There's also what are called biologics or biological modifiers, immunotherapy. And you don't have to know in depth about these. Like whatever I have on my slides is usually as deep as you need to go. But there's a lot of drugs in this class, but I'm going to try to sum it up and bring it together. The big medications that you definitely want to know about are what are known as DMARDs, or disease modifying anti-rheumatic drugs. I think that's right. These are specific to rheumatoid arthritis, and they help to slow down the disease progression. So this is not something that has a cure. We're really just trying to slow it down and stop it from getting worse. Because when it gets worse, then we lose that those joint function, the joint abilities, and things like that. And we can have those really bad deformities. So really, we're just trying to slow it down. We can't stop it. We can also do joint replacement, or they can remove if the synovial membrane or where the joint space is really inflamed or messed up. They can remove it, replace it, or that gets removed and replace it. And then occupational and physical therapy can help because they can have a lot of day-to-day stuff that they really need help with, and we want to protect their joints. So going deeper into some of the meds, the main meds that you're gonna want to know about. These are three of the top DMARDs that you're going to see used. There's methotrexate, sulfasalazine, and hydroxychloroquine. Um, and these are like this is Plaquenil. Sulfasalazine is a sulfa drug, and methotrexate. You'll see these used in a variety of conditions, but they help to stop the body from attacking itself so much. They help with a lot of the autoimmune process. But the one thing you'll kind of see the general trend here is all of these can affect your bone marrow or your ability to fight infection. And so we really want to be super cautious with these patients, because anyone with an autoimmune, like it's kind of autoimmune is a lot like when we talked about hypersensitivity, where the body's overreacting. Well, in the autoimmune, it gets to the point where it's attacking itself and it doesn't recognize itself. So think of like a dog that's chasing its own tail, and it doesn't realize, hey, this is me. It ends up can cause some very serious issues. So the only way we can really do it is like, the immune system has lost its mind. So all we can really do is try to quiet the immune system or get it from not reacting so much. So, but as a side effect of that, their immune system is not going to be as strong. So I really need to do infection prevention. This is why a lot of people with autoimmune were top of the list when, the COVID vaccine came out, because they really needed to protect people from having this high risk of um, issues related to, if they get COVID, they don't have as strong of an immune system. So they really needed to be frontline to get the vaccination. Anyway, so methotrexate, some other things that can cause complete bone marrow suppression, which means your red blood cells, your white blood cells, and your platelets can all be suppressed. And so we want to be looking for anemia, bleeding issues, and stuff too. All of these can be hard on the liver and kidney, mostly, I want to say, at least the liver, but most of them liver and kidney. And we're not going to give you some trick question. It's like, all these except for this one, and this one may affect the liver and kidney too. But just know that they're all hard on your filters. A lot of them you want to maintain good fluid intake is going to be important. For sulfasalazine, a lot of the sulfa drugs, they can turn things orange or yellow, so just let them know so they're not freaked out by that. And then sunscreen is going to be needed because they can have that photophobia. Hydroxychloroquine, excuse me, or Plaquenil. One thing that you want to consider is that the big thing that can happen is like vision changes. So they usually need regular serial vision exams. We need to get a baseline and really be looking for those changes. Other sensory stuff is it can cause changes to hearing, so watching that closely. The BRMs are also what's known as the biological response modifiers, and there's a whole lot in this class. You do not need to know the individual names. Just know for this class, they increase your risk of infection. You cannot get any live vaccines while you're on these. So that's like one where your body has to actively fight the infection. So most people use dead viruses anyway for most of the vaccines, but there are some that are live, so they cannot get those, or they have to get those before they start treatment on this. And then again, watch your organs. So, like I mentioned, joint protection is so key for patients with rheumatoid arthritis. So, we're going to do things like lightweight splints that are really going to help. Because remember, this is a lot of stuff in the hands, usually. It can be in the feet too, but it's usually in the hands. So, I want to protect and support those joints so they don't get contractures, other issues. It cannot be prevented, but if it's caught early, we can decrease that joint damage. And so, the other thing you want to consider here is like all the meds that I just went through is that like people with rheumatoid arthritis have to take medications the rest of their life in order to prevent things from getting worse. People with osteoarthritis, there's no med to stop them from having the issues. It's all lifestyle. So osteoarthritis is a lot of like lifestyle stuff that needs to change to decrease stress on their joints. People with rheumatoid arthritis should need to focus on their med compliance. Now, it's not to say other stuff doesn't need to be done and there's no lifestyle stuff that needs to change, but it's not a result of a lot of times lifestyle choices and things like that. This is something that, is not like it can't be prevented. A lot of times it's genetic, which I guess I didn't really go into risk factors and stuff, but it's not always well understood why people get autoimmune, but a lot of times there is a genetic factor. And so with these patients, like med compliance, and it can be hard, especially if they're not having symptoms, they may stop their medications. Remember, who gets this? Younger patients in their 30s. And a lot of times it's more common in women. And so there's a lot of issues with some of these meds not being safe for pregnancy. So definitely if they're thinking about getting pregnant or wanting to get pregnant, they need to talk with their doctor. But yeah, anyway, but kind of get in your mind that what I'm doing for rheumatoid arthritis is I'm managing a chronic condition. They have to take meds to stop their condition or keep their condition at bay or stop it from getting worse or try to slow it down. Whereas osteoarthritis, they don't have to take any meds ever if they don't want to. There's no med that's going to fix that patient. There's med that can treat their symptoms, but none of the meds actually fix the problem. The meds for rheumatoid arthritis can help fix the problem. When I say fix, I don't mean cure. What I mean is that they can make the problem better. There's no med for osteoarthritis that can actually fix the cushion issue. Anyway, hopefully that makes sense. So other things, protecting small joints, things you want to keep in mind is we want a neutral position for joints. Changing positions frequently is helpful because we don't want to put too much pressure for too long. Repetitive motions, especially kind of think like carpal tunnel. We talked about those repetitive things like typing on a keyboard, sewing, that kind of stuff can be hard on these patients. Want to avoid heavy lifting. We want to try to think about all the things that we can do to use the strongest joints. Like we don't want to strain our small joints, and then try to do like work. What do they say? Like work smart, not hard in order to lift things or move things. We just have to think a little bit more because sometimes we can just very commonly put a lot of stress on our joints without even thinking about it. So, like it talks about here, use your palms rather than your fingers to get up from a chair. You may think, Psh, I don't use my fingers. Just it's very hard to do with that, like when you're trying to actually actively watch it, but watch other people and how they get up, and you'd be surprised how much we use our small joints sometimes instead of our larger joints to really help us. Most people are not standing up from a sitting position using their legs, which are definitely a stronger joint than our hands or our arms. All right, so let's get some practice here. For each of the following activities, write whether a nurse should recommend doing the following for a client with rheumatoid arthritis. So these are going to be some joint protection things. Let's see. Should I tell someone who has rheumatoid arthritis to wring water out from a sponge? So this is actually something that's very bad. This twisting motion, you have to imagine like a twisting motion is going to be really hard on the hand joints. This is going to take put a lot of stress and strain. So this is not something that I would recommend. Using an electric can opener. Well, that's great. If it's an electric can opener, they don't have to do that twist one like that manual can opener, which can cause a lot of strain on their joints. So an electric can opener is a good recommendation. Wringing water out, bad. Encourage them to ask for help and delegate tasks. This is something most people don't want to do, but it's something people need to do. So there might be some things that, like opening a can of what do you call it, like a can of jelly or something like that, or help with some of the fine motor stuff, like maybe making a sandwich or little things like doing some cleaning, but asking for help delegating tasks, like we need to protect their joints. It's not that they can't do anything, but we need if you have rheumatoid arthritis, you need more help. Using arms to carry the laundry basket. So let's see, if they're using their arms, then they're not putting stress on their hands. So that sounds good. Now this might seem weird because you're like, oh, but they're saying instead of carrying the basket with your hands and putting that stress on your hands, to use your arms to carry. Avoid frequent position changes. Well, I think that that's not a good thing because I want them to change positions and move. Like staying in the same position can actually be very bad for them. Now, it's not that they have to constantly be moving, but they do need to be, we do not want them stationary or staying in the same position. So far, wringing water out, bad. Electric can opener, good. Ask for help and delegate, good. Arms to carry laundry basket, good. Avoiding frequent position changes, bad. Writing with a pencil rather than typing. Well, both of these things put strain. Like if you think about holding a pencil or typing, both of these things are about equal when it comes to the strain that they can put on. So there's not one that's better than the other. Knitting or sewing increases dexterity. I'm sure it does, but it also increases joint stress. So no writing with a pencil. It's not that they can, when I'm saying no, I don't mean they can never do this, but that statement that writing with a pencil rather than typing is better is not true. Knitting or sewing does increase dexterity, but I'm not going to tell a patient with rheumatoid arthritis to do it because it's that repetitive motion. So that's also a thumbs down. Sit on a stool during meal preparation. Well, this is great because it does take, it puts some stress off of the patient's joints and allows for a little bit of a reprieve. So that's good. Wearing Velcro on shoes and other clothes. So this might not be very stylish, but it's going to be a lot easier and less fine motor for them to have to work with. Think everything with their hands. We want to decrease the amount of stress or work or repetitive motion. So Velcro is good. Using a cane or walker for support. This is also good. I'm using whatever we can to offload those joints. Let's see if I can go. So with these patients, it's going to have some similarities to osteoarthritis, but look at some of these key differences, especially for a patient, because remember, they have systemic symptoms. Their body is literally attacking itself. Rest is super key for these patients. Yes, we do need rest in osteoarthritis too, but the book actually says these patients need a daytime nap and also 8 to 10 hours of sleep. Now, does that mean that they're actually getting it? Maybe not, but it is key for these patients. Exercise should be a balance of them staying active, but also doing, like we want them moving, but also doing stretches or joint range of motion exercises. Then we exercising in warm water can be helpful for these patients to make things a little bit easier because warm water does help relax stiffness and allow for better, um, what do you call it? Better movement. And I talk about this farther down where, remember, these are the patients that have prolonged morning stiffness. So, what we actually usually tell them for that is to start the morning out with a warm shower or bath, and that will help to with that prolonged stiffness. Um, Medication compliance is key for these patients, and it's key because remember, like, they need these medications if they're gonna prevent serious deformities. People with osteoarthritis, they want their medications and, they definitely need the help for the symptoms, but it's not actually gonna fix the disease process itself. We talked about heat for stiffness, ice for pain, 'cause remember this is inflammatory, so ice can help more in rheumatoid arthritis than maybe for osteo. It can help in both. Sometimes it's just a preference, but just know heat for stiffness, ice for pain. Avoid putting joints in a flexed position to avoid contractures. So remember, with some people we like flexion. Remember back pain people, I like flexion in their hips and knees. I do like what do you call it? Yeah, I think I'm gonna just stick that with back pain, but for other patients, flexion is not a good thing. And so, rheumatoid arthritis is another one where I would not want them to be too flexed, because especially like if their fingers or other things are flexed, it can lead to contractures. So these people can also have systemic issues that I want to consider. Aside from the fatigue, they can also have weight loss. And so I want to support good nutrition. Their issues relate back to the fact that it's going to be harder to prepare food. It's exhausting and they have to use their joints a lot. So this is where they need to ask for help and delegate. Something to consider is a lot of these patients may be on or off corticosteroids, systemic ones. And remember the three things I said about systemic corticosteroids: makes you hungry, which means you can gain weight. It also causes your blood sugar to go up and then suppresses your immune system. So I'm just kind of keeping that in mind. But they may gain weight temporarily. But sometimes that's one of the benefits of using steroids for rheumatoid arthritis is that it can help to for them if they're struggling with weight loss to gain weight. But we usually don't have people long term on corticosteroids. Anyway, next is all about gout. Hopefully now you can kind of start to see some of these differences between osteo and rheumatoid arthritis. But I mean, I can talk for days about this, but start writing it out and really looking at it, putting pen to paper. Don't just listen to this video, go and write it out and start looking at those differences. Visual will help you so much. And then you can add in gout after you watch the next video if you can tolerate me for that long. See you for the next one.